Part A. Extract 1. Questions 1 to 12. You hear an orthopedic surgeon talking to a patient called Mihira. You now have 30 seconds to look at the notes.
Hello, and thanks for coming in, Mihira. Let's get straight to it. What seems to be the trouble today?
Well, doctor, it's my right knee. It's been acting up for what feels like an eternity now. It all started a few months ago as a dull ache, but now it's a sharp, stabbing pain, especially when I go up or down stairs. It's particularly bad in the mornings. I feel this stiffness that takes a good half hour to work out. I also hear a grinding or clicking sound, almost like a crepitus, when I bend it. The pain often radiates down my shin, and sometimes my calf feels tight, too. The knee itself feels warm to the touch and looks a little swollen. The discomfort has been gradually worsening over the past few days. It's really affecting my work as a chef. I'm on my feet all day.
I see. That sounds very uncomfortable. Mihira, have you tried anything to alleviate the symptoms?
Oh, absolutely. I've been taking over-the-counter paracetamol and ibuprofen, but they only offer temporary relief. I tried a topical diclofenac gel as well, which helped with the superficial warmth but not the deep, gnawing pain. I also started wearing a compression sleeve, but it makes the area feel more restricted, not less. I even tried some physiotherapy exercises my friend recommended, but that seemed to aggravate the stiffness, so I stopped.
And what about your past medical history? Any previous injuries to that knee, Mihira?
No major injuries, no. Just a minor twist playing tennis years ago that resolved on its own. I do have a history of osteoporosis in my family. My mother has it quite severely. And I was diagnosed with polycystic ovary syndrome about 5 years ago, which I manage with metformin. I'm not allergic to any medications that I know of.
Okay, based on what you've told me and the physical examination, Mihira, my provisional diagnosis points towards osteoarthritis of the knee. The crepitus, morning stiffness, and pain with weight bearing are all classic indicators. However, to be certain, I want to get a few tests done. We'll start with an X-ray of the knee to look for any joint space narrowing or bone spurs, also known as osteophytes. Given the warmth and mild swelling, we'll also assess for signs of inflammation or joint effusion. An MRI scan might be necessary to get a better look at the soft tissues, such as the menisci and ligaments, to rule out any tears.
Okay, I got it.
Mihira, in the meantime, before we get the test results back, I'm going to prescribe you a different anti-inflammatory. Let's try naproxen. It's often more effective for this type of pain. Take it twice a day after food. And continue with the cold compresses to help with the swelling. We'll review your condition once we have the test results. Any questions?
Not right now. Thank you, doctor.
Extract 2. Questions 13 to 24. You hear a nurse talking to a patient called Mihira. You now have 30 seconds to look at the notes.
Good morning, Mihira. Thanks for coming in. Please have a seat. So, I see from your referral that you're experiencing some discomfort. Can you tell me what's been going on?
Oh, good morning, Henry. Yes, it's just awful. It started a few weeks ago, but it's gotten progressively worse. I've been getting this incredibly sharp pain. It's not a dull ache, it's like a searing, almost electric jolt, right at the base of the skull. It's not constant, but it's unpredictable, which is the most frustrating part. It just comes out of nowhere. It shoots up into the back of my head and sometimes even radiates down the neck.
I see. And on a scale of 1 to 10, how would you rate this pain when it's at its worst?
A solid 8, it's debilitating. It completely stops me in my tracks. I'm a bookkeeper, you know, so I spend hours hunched over a desk, staring at a screen. It's making it nearly impossible to focus on the ledgers. The eye strain is another thing. I feel like my vision is getting blurry, and the fatigue is just immense. I'm so exhausted by the end of the day.
That sounds incredibly challenging, Mihira. Have you tried anything to alleviate the pain?
I've tried everything. My general practitioner suggested some over-the-counter NSAIDs, but they barely touched the pain. I tried paracetamol too, no luck. I even tried a heating pad and some topical analgesic creams, you know, the ones with menthol. They give a momentary distraction but don't fix the underlying problem. My husband, bless his heart, even bought me a cervical pillow, but it didn't seem to make a difference. The pain is so localized, I just don't know what to do anymore.
Right. And just to confirm, you have no other significant medical history, no previous neck injuries, or musculoskeletal issues. Any family history of arthritis or similar conditions?
None that I'm aware of. My parents are both in good health, no major issues. I did have a minor car accident about 5 years ago, a fender bender, but I had no injuries then. My husband thinks it's probably a pinched nerve or something like that, but I just don't know. I'm hoping you can shed some light on this.
Okay, let's have a look. I'm going to perform a few examinations to assess your range of motion and palpate the area. I'll need you to turn your head from side to side, and also look up and down. This could be indicative of cervical spondylosis, but we'll need to confirm that. We'll likely need to start you on a course of muscle relaxants, and maybe a stronger anti-inflammatory. I'll also recommend some specific exercises and postural adjustments you can make at your desk. We'll start with a 2-week course, and then review your symptoms.
Thank you, Henry. That sounds like a plan. I just want some relief.
Okay, let's have a look. I'm going to perform a few examinations to assess your range of motion and palpate the area. I'll need you to turn your head from side to side, and also look up and down. This could be indicative of cervical spondylosis, but we'll need to confirm that. We'll likely need to start you on a course of muscle relaxants, and maybe a stronger anti-inflammatory. I'll also recommend some specific exercises and postural adjustments you can make at your desk. We'll start with a 2-week course, and then review your symptoms. Okay, let's have a look. I'm going to perform a few examinations to assess your range of motion and palpate the area. I'll need you to turn your head from side to side, and also look up and down. This could be indicative of cervical spondylosis, but we'll need to confirm that. We'll likely need to start you on a course of muscle relaxants, and maybe a stronger anti-inflammatory. I'll also recommend some specific exercises and postural adjustments you can make at your desk. We'll start with a 2-week course, and then review your symptoms.
Part B. In this part of the test, you'll hear 6 different extracts. You'll have time to read each question before you listen. Question 25. You hear a social worker called Mihira talking to a care home manager.
Sarah, about these music therapy sessions. While most residents respond well, we're seeing some unexpected reactions. Mrs. Ellis becomes quite distressed during group sessions, yet thrives during individual piano time. It's puzzling.
That aligns with what we've noticed, Mihira. The dementia patients who resist morning care become remarkably cooperative when their favorite songs play during bathing. But Mr. Harris, he covers his ears at any music, yet his daughter insists he loves concerts.
And here's what's fascinating. Those who can't recall breakfast can remember every lyric to songs from their youth. The neurologist suggested this might help rebuild neural pathways, though we should monitor Mrs. Ellis's agitation closely.
We could trial shorter sessions for sensitive residents. The afternoon group shows better engagement than our morning attempts, possibly due to sundowning patterns.
That's insightful. Perhaps we're seeing two distinct benefits: cognitive stimulation for some, emotional regulation for others. The key is personalization.
Agreed, Mihira. Let's document which genres work best for which behaviors. That Beatles playlist worked wonders for meal times.
Question 26. You hear a GP called Mihira talking to a community nurse.
Dr. Mihira, about Mrs. Henderson's visit today, I've noted down the usual observations. She mentioned feeling a bit out of sorts.
Right, Sarah. I've seen her file. What's the plan for her? We're trying to manage her fluid balance, so the diuretics are key. It's the consistency of recording her weight that I'm worried about. The last few entries are a bit erratic.
I see. She keeps saying she feels like her ankles are puffy. I've tried to explain it's likely just a bit of swelling from being on her feet, but her son, Peter, thinks it's a symptom of her heart condition. He's quite insistent, and it's making her anxious. I documented that.
That's a good point to capture. Her son's concern, I mean. It's not clinically significant yet, but it's a social factor we need to consider. We need to reassure her, of course, but the key is to get that weight data consistently. That's the real measure of her fluid retention. Her husband, David, mentioned she's also getting a bit short of breath on exertion, but she thinks that's just her asthma acting up.
Yes, Dr. Mihira, I spoke to David too. He's the one who does most of the cooking. He's worried about her salt intake. He's quite diligent about following our diet sheets.
Good. So, her fluid retention is our primary concern for now, and the best way to track that is with reliable daily weights. That's a directive for your notes on the next visit.
Question 27. You hear a doctor called Mihira talking to a ward manager.
I noticed the shift chart shows the same nurse recorded for both the early and late rounds yesterday. How did that happen?
Mihira, we had two nurses with similar surnames, Harris and Harrison, covering the ward. The system autofilled the first name it recognized, and no one spotted the error until this morning.
That explains the double entry, but the times also look out of order.
Yes, because the early round was logged after the late one. Harris stayed late to finish notes for a patient with breathing trouble, while Harrison had already left after helping someone with dizzy spells.
So the breathing trouble case got linked to the late round?
Correct, and the dizzy spell note ended up in the morning list. Both patients were stable, but if someone checks the chart quickly, they might think observations were missed.
We'll need to fix the chart and remind the team to check autofill before saving.
Mihira, I'll also adjust the order of entries so they match the actual rounds.
Question 28. You hear a nurse manager called Mihira talking to a physiotherapist.
David, about the new mobility machine, several nurses reported it's causing confusion. Patients keep pressing the wrong buttons, and yesterday Mr. Jenkins nearly fell trying to adjust it himself.
That's concerning Mihira. The shoulder support model should prevent that. It locks automatically if weight shifts unevenly. Are they using the blue straps? The old black ones don't secure properly.
They're using blue, but the issue seems to be the display panel. The up/down arrows look identical to the tilt controls. Mrs. Thompson kept changing positions accidentally when she meant to adjust height.
Right, we should cover those buttons during basic transfers. The real function is for advanced rehab. The gradual resistance settings help rebuild muscle control without strain. Maybe we could mark the essential controls with colored tape.
Good idea. And we should emphasize it's not for independent use yet. The hand grip sensors are sensitive. They detect tremors for therapy adjustments, but patients interpret vibrations as malfunctions.
Exactly, Mihira. Let's retrain staff on the core functions first. The advanced features can wait until patients progress.
Question 29. You hear a physician called Mihira talking to a surgeon.
Hi Alex, thanks for calling back. I'm a bit concerned about our patient, George. He's post-op from his hernia repair, and he's complaining of persistent stomach upset. I've noted down that he's been quite nauseous, but also mentions a sort of gurgling feeling, like a cramp, that's not getting better.
Okay, Mihira, I've just been looking at his chart. We started him on that new pain reliever yesterday. It's a fairly potent one, but his pain relief has been good. It's possible the nausea is a direct side effect. We should probably adjust the dosage, but I don't want to compromise his comfort.
I agree. The pain management is critical for his recovery. The main issue is that he's worried it's something more serious, perhaps a bowel obstruction. He has a history of irritable bowel syndrome, so he's quite attuned to these kinds of symptoms. I'm trying to reassure him that his bowel sounds are normal and his abdomen is soft. The nausea is likely from the medication, not a surgical complication.
He's been eating well, hasn't he, Mihira? Small, frequent meals. That's what we advised. As long as he's tolerating food, I'm not overly concerned about a blockage. So you think the best course of action is to reduce the pain medication slightly and see if the nausea subsides?
We can't eliminate the pain medication entirely, but we can manage the side effects. It's all about finding that balance. I'll make a note of it in his file for the nurse on the ward.
Question 30. You hear a nurse called Mihira talking to a colleague.
Sarah, about the handover, I noticed Mr. Thompson's notes said he needed assistance with meals, but actually he's been managing fine since Tuesday. The physio team upgraded his mobility rating yesterday.
That's good, Mihira, but his medication schedule changed this morning. He's now on the new pain relief before meals instead of after. Did the evening team mention his reaction to the first dose?
No, they focused on his wound dressing frequency. The important thing is he needs his antibiotic exactly at 8 p.m. The consultant stressed this can't be late because of the infection risk. His daughter reminded us too when she visited.
Right, Mihira, I'll highlight that. Also, his blood sugar checks moved to before meals instead of after. But let's keep assisting with his drinks. He's still shaky with hot liquids even though he can feed himself now.
Got it. And we should note he prefers his main meal at 6 p.m. sharp since starting the new medication. He gets nauseous if it's later. The nutritionist approved this change.
Part C. Extract 1. You hear a pharmacist, Mihira, and an interviewer discussing about non-prescription medication.
Welcome, Mihira, a seasoned pharmacist, to discuss the nuances of non-prescription medication. Mihira, many people rely on these over-the-counter remedies. But are they really as helpful as we think, or is there a hidden risk?
Thank you for having me. That's a crucial question. Non-prescription medications, when used correctly, are incredibly helpful. They provide accessible and immediate relief for minor ailments like headaches, fevers, and seasonal allergies. This allows people to manage their health proactively without needing a doctor's appointment for every small issue. However, the key is correct use. Misuse, such as taking more than the recommended dose or ignoring contraindications, can pose significant risks. So, their helpfulness is contingent on informed usage.
That makes sense. Mihira, what, in your professional opinion, is the main reason these medications are so widely available? Is it convenience, or something else driving this trend?
The primary reason is to alleviate pressure on the healthcare system. By empowering individuals to self-manage minor, predictable health issues, we free up doctors and emergency rooms to focus on more serious and complex conditions. This also helps to reduce overall healthcare costs for both patients and the system itself. It's a strategic public health measure, not just a matter of convenience, though that's certainly a benefit.
That's a fascinating perspective. So, Mihira, when a patient comes to you for advice, how do you go about recommending a non-prescription medication? What's your process?
My recommendation process is highly personalized. First, I engage the patient in a brief consultation to understand their symptoms, medical history, and any other medications they might be taking. For example, if someone has high blood pressure, I must avoid recommending certain decongestants. It's about identifying potential drug interactions and contraindications. My role isn't just to sell a product. It's to ensure it's the safest and most effective option for that specific individual. I always advise them on the correct dosage and potential side effects.
That attention to detail is vital. And what about age sensitivity? Mihira, are there specific non-prescription medications that are particularly sensitive to a person's age?
Absolutely. Age is a critical factor, especially with children and the elderly. Children's bodies metabolize drugs differently, so what's safe for an adult can be toxic for a child. This is why many children's medications are formulated with lower concentrations and specific dosing instructions based on weight or age. For the elderly, their organs, like the liver and kidneys, may not function as efficiently, which can lead to a buildup of medication in their system. This necessitates a lower dosage to prevent toxicity. So, age sensitivity is a major consideration for both pediatric and geriatric care.
So, age impacts dosage, but how do you determine the appropriate dosage for a non-prescription medication? Mihira, is it always what's written on the box?
While the packaging provides a general guideline, a pharmacist can offer a more precise recommendation. We often follow the manufacturer's maximum dose, but might suggest a lower starting dose, especially for first-time users or those with other health conditions. The goal is to provide the minimum effective dose to achieve the desired therapeutic effect with the least risk of side effects. For example, a patient with a milder headache might only need 1 tablet instead of 2. It's about tailoring the dose to the severity of the ailment and the patient's individual profile.
Lastly, for certain non-prescription medications, Mihira, how do you report their dispensing to the health department or other regulatory bodies?
We don't typically report the sale of all non-prescription medications. However, for certain drugs, such as those containing pseudoephedrine, a stimulant, we are legally required to log the sale in a registry. This is a precautionary measure to prevent their misuse in the illegal manufacture of other substances. So, for these specific controlled substances, we record the patient's identification to ensure accountability. It's a targeted reporting system designed to address public safety concerns, not a blanket reporting for every over-the-counter item.
Extract 2. You hear a surgeon talking about wound infections at the Mihira Research Institute.
Good morning, everyone. I'm Dr. Lopez Marcus, and I'm pleased to present today's session on wound infections here at the Mihira Research Institute. Wound infections remain a significant challenge in healthcare, impacting patient recovery and placing considerable strain on our resources. Understanding the multifaceted nature of these infections is paramount for effective prevention and management. Firstly, let's consider the common causes of wound infections. These are typically multifactorial, rarely stemming from a single source. The patient's intrinsic factors play a crucial role, including their age, nutritional status, underlying chronic conditions like diabetes or compromised immunity, and even their lifestyle choices such as smoking. Extrinsic factors, directly related to the wound environment and care, are equally important. These include the nature of the injury itself, whether it's a surgical incision, a traumatic wound, or a chronic ulcer, the level of contamination at the time of injury, and the subsequent wound management practices. Inadequate cleaning, improper dressing techniques, and delayed wound closure can all significantly increase the risk of infection. At Mihira Care, we emphasize meticulous surgical techniques and sterile environments to mitigate these extrinsic risks from the outset. Moving on to classification, wound infections are generally categorized based on several criteria. One primary method is by depth and tissue involvement, ranging from superficial infections involving only the skin and subcutaneous tissue to deep infections affecting fascia, muscle, or even organs. Another classification considers the timing of onset. Early infections that manifest within the first 30 days post-surgery, and late infections occurring thereafter. Additionally, infections can be classified by the type of infecting organism, whether it's bacterial, the most common, viral, fungal, or even polymicrobial, involving multiple pathogens. Finally, the severity of the infection, ranging from localized signs of inflammation to systemic manifestations like sepsis, dictates the urgency and intensity of treatment. Accurate classification is crucial for guiding appropriate antimicrobial therapy and surgical interventions. Mihira Care protocols mandate thorough documentation and assessment for precise infection classification. A key question is whether wound infections exhibit any similar patterns. While each infection is unique, certain predictable patterns do emerge. For instance, surgical site infections often present with the classic signs of inflammation, redness, warmth, swelling, pain, and purulent drainage, typically appearing between the 5th and 7th postoperative days. Certain types of surgery or patient comorbidities are also associated with a higher propensity for specific types of infections. For example, infections following bowel surgery often involve gram-negative bacteria. Moreover, the increasing prevalence of antibiotic-resistant organisms is creating a concerning pattern of infections that are more difficult to treat and may have prolonged courses. At Mihira Care, our surveillance programs continuously monitor these patterns to identify potential outbreaks and inform our infection control strategies. The impact of wound infection on patients is substantial and multifaceted. Beyond the obvious physical discomfort, pain, and delayed wound healing, infections can lead to prolonged hospital stays, increased need for further surgical procedures, and a higher risk of complications, including sepsis and even mortality in severe cases. The psychological impact is also significant, with patients often experiencing anxiety, fear, and a diminished quality of life due to prolonged illness and uncertainty about their recovery. The financial burden on patients and their families, due to extended hospitalizations and treatments, can also be considerable. Mihira Care is committed to providing comprehensive support to minimize these adverse impacts on our patients. Wound infections also place a significant burden on healthcare staff. Managing infected wounds requires increased nursing care time for dressing changes, administration of antibiotics, and monitoring of the patient's condition. Surgeons may need to perform additional debridement procedures or manage complications. The emotional toll on staff can also be significant, especially when dealing with severe infections or patients who experience poor outcomes despite best efforts. Furthermore, the risk of healthcare-associated infections necessitates strict adherence to infection control protocols, adding to the daily workload. At Mihira Care, we provide ongoing training and resources to support our staff in effectively preventing and managing wound infections, recognizing the crucial role they play. Finally, How does early detection help minimize wound infection? Timely identification of infection allows for prompt initiation of appropriate treatment, such as antibiotics and wound debridement, which can limit the local spread of the infection and prevent systemic complications. Early detection also facilitates timely adjustments to wound care strategies, addressing any contributing factors like inadequate drainage or suboptimal dressings. Furthermore, early recognition of unusual infection patterns can trigger investigations into potential outbreaks or breaches in infection control practices, allowing for swift corrective actions. Mihira Care strongly emphasizes the importance of vigilant wound assessment and early intervention as key strategies in minimizing the impact of wound infections and improving patient outcomes. Thank you.